From the 22 News Plus studio, this is 22 News in Focus with Patrick Berry.
Hello, everyone, and welcome to this edition of InFocus. I am your host, Patrick Berry. There is an epidemic that's taking place right now. It's hand, foot, and mouth disease. I've been very fortunate to be joined here in the studio by the new chair of the Department of Pediatrics at Baystate Health, Dr. Matthew D. Guglielmo. Doctor, thank you so very much for joining me. I appreciate you giving me a little bit of your time. I know nothing about hand, foot, and mouth disease, but from what I've been reading, it is an epidemic right now. It's everywhere, and I think the state of Massachusetts is for not good, but bad, kind of on the leading edge of it, meaning there are more cases in Massachusetts than other parts of the country. But let's go back and start with what is it?
Sure. I agree with you about this mini epidemic, if you will. And in our practice, we're seeing lots and lots and lots of it. That happens every couple of years. It's been interesting.
So it's cyclical.
Over my career. Somewhat. Yeah,
okay.
We don't understand why. So hand, foot, mouth is a viral infection. We call it hand, foot, mouth because typically the symptoms arise in your hands and feet and your mouth, or one or the other. So it's a skin rash and also an oral ulcerative rash. It can be as benign as you've got a couple of bumps here and there, and somebody thinks, oh, those look pretty familiar to maybe our hand, foot, mouth because they're on your palms, or they're on your soles, or they're on the sides of your hand or the sides of your feet. And other times it can be a florid, everywhere in the body sort of rash, starting in that part of the body. Those parts of the body can even involve the buttocks. The oral ulcers are quite painful, and they are sort of reddish, whitish. They can be blistery. But it's a viral infection, and the family of viruses are viruses that can cause anything from upset tummy to skin rash to fever, which is why we might see different cycles, because it might be different viruses causing the same clinical picture.
Is it only children, or can anyone get it?
Anyone can get it.
Okay.
It is predominantly kids under 5-6 years of age, but it is something that you and I can get, or you can get multiple times. Sure.
That's an interesting point. So you can get it multiple times. So is this one of those things you see at a daycare or something? It keeps coming around and around and around every couple of months or every year?
Yes, it's very common in childcare settings, schools and daycares. It's transmitted through your snot, your spit, blister fluid if you have a popping blister from the rash, and through feces. If kids if they're not potty trained yet.
And kids, we know they're not that clean, so they're wiping their nose and touching the toilet seat and everything. And it goes from one kid to the next.
Exactly, surfaces which are just hard to clean. So a lot of that close proximity, definitely. For adults, you usually get it from a child or a patient.
In my head, I'm thinking chickenpox. That type of thing where it's always there. And this is the same idea, right? It's kind of always there.
It's more reinfection. Because there's just a family of viruses called enteroviruses that can cause it. Coxsackie virus, probably more than you needed to know, is the most common one to cause it. It's just called Coxsackie virus. But it is not something that you carry around like you would carry around varicella or chickenpox.
Okay. What are some of the symptoms again? Repeat those.
Sure. Some kids don't have any sort of harbinger symptoms where, something's coming. But they can have fever, irritability, tummy ache. But essentially, you have to break out in either a rash or oral ulcers or both. So skin and mouth.
So by the time you see the visual part of it, is the contagion point already gone?
Yeah, great question. So in the beginning, you're infectious even before you show signs, and you remain contagious and infectious for about a week after signs start, through your bodily fluids, right?
Okay.
The skin rash themselves, not contagious unless it's an open blister. And the mouth sores, wouldn't really transmit the virus through your saliva.
So if you have, if my child has the hand, foot, and mouth disease, and they've got the blisters on their hands, and they touch me with those blisters, that's not, like poison ivy, that's not going to transfer it.
It's not going to transfer it. If the fluid in their blister gets on you and you get it in your mucous membranes, mouth, nose, eyes. Right. There's a theoretical risk you could get the virus that way. Whether it'll turn into hand, foot, mouth, hard to say. But that's the way of contagion.
Now, there is if I understand correctly, there's like chickenpox, there's no cure for this. There's unlike some other diseases. I was going to say measles, but measles is back. But there is no cure for hand, foot, and mouth disease, right? Just
That's correct.
basic treatments once the symptoms.
It's all about symptom treatment and keeping an eye out for sort of those very rare situations where a kiddo gets more sick than you might imagine from something that's pretty common. But no, there's no cure.
So is there any preventative measures that parents or children can take?
It's essentially no, other than keeping your surfaces clean like you would for any other cold virus or other virus that you can pick up. In fact, if we keep kids out of daycare, we know that that does not prevent the spread of hand, foot, mouth throughout that childcare setting, because it's probably already there. It's probably on surfaces. If you just have one kiddo and they come back when things are not, when they're feeling better, that's not going to lead to more infections. It was already there. And studies have shown it doesn't really change things if you exclude them from school the entire time they're sick.
Interesting. We are up on our first commercial break. We will be right back right after this, so stay with us.
This is 22 News in Focus with Patrick Berry. This is 22 News in Focus with Patrick Berry.
Welcome back, everyone, to this edition of InFocus. I am your host, Patrick Berry. Across the desk from me is the new chair of pediatrics at Baystate Health, Dr. Matthew D. Guglielmo. Doctor, thank you for joining me. I greatly appreciate your time. Before we get back onto hand, foot, and mouth disease, you're the new chair of pediatrics at Baystate. Tell me a little bit about your transition here to Western Mass.
Sure. Happy to. Thanks for asking.
And your past role in pediatric medicine.
Sure. So I've been a pediatrician since 2007. I've spent time in a private practice setting as a general, go see your doctor for well visits and checkups and sick visits doctor. I worked in an academic health system, which means there's a lot of teaching, some research, there's involvement with the community and advocacy. As a doctor who took care of kids with tummy issues, I helped train the next generation of pediatric workforce, pediatric residents through precepting and supervision. And then ultimately, I was the chief or the leader of a group of pediatricians who took care of inpatient and outpatient children, our child abuse team, and our obesity management team. That was the last job I had before becoming a chair. And my transition was, I wanted to see where I could go, that I could make a different kind of impact, leading and supporting an entire department,
right?
All the specialists, all of the outpatient doctors.
So
I've been here 2 months.
When you look at, when you go back in time, when you entered medical school, all the different roles of care, why pediatrics? I know you're a dad, but why was that a driving factor in it or no?
I had two experiences that I think set the tone for me. One was I got to shadow a pediatrician in her office. She ended up becoming my children's pediatrician.
Okay. And
I just loved the taking care of the family and the child and learning all of her techniques to deal with 0 to 21-year-olds. They're so different spectrum. And then the second was learning that you can prevent a lot of illness in pediatrics, a lot harder to do in adult patients.
You know, it's interesting. I look at pediatricians who deal with, because it's 0 to 21, but when you're dealing with the younger end of that, I'd say 6, 7, maybe 5, 6, 7, age 5, 6, 7 and below, being very similar, and please don't take this the wrong way, like a veterinarian, only in the sense that communication, what hurts, a dog can't tell you, and a 4-year-old has a difficult time telling you.
Absolutely.
How do you deal with that? Or do you rely more on the parent in that sort of environment?
So it's important to rely on the parent for sure. They know their kids the best. The fun thing about pediatrics is learning about normal and abnormal child development, from the gurgling, wrinkling, crying 3-day-old,
right,
to the 6 or 7-year-old that can tell you what your stethoscope is for. And as you watch kids' development, you can meet them where they are. So if a kid has tremendous stranger anxiety at a certain age, you are not going to rush right into that exam. You are going to play and be silly and distract them and tend to listen to the parent's heart by touching their shoulder with a stethoscope.
Right.
You're going to have fun because you want to put them at ease. If they're 4 and they're precocious and they know what they're doing, you just let them run the show and they answer all the questions for you. You pick up on those cues, you know how to approach different ages, and then you learn from great pediatricians like the one I mentioned. How do you examine the mouth of a screaming toddler?
Exactly.
How do you make
well, they're already screaming, so the mouth's open.
But they're also squirming and wriggling. So it just it takes some real art. I've seen some great pediatrician magicians figure out ways to really distract kids with little magic tricks. I've never really picked them up that well myself, but there are some out there. And anything you can do to distract and get what you need. But you're very right. That is a common statement. I don't take any offense. It's hard to get the unable to communicate kids to communicate. Last thing I'll say is we learn in pediatrics how to walk in a room and within 5 seconds recognize if that kid is sick or not so sick. And that's really important because if they're sick, you have to act pretty urgently. You don't have time for the art, right?
Right.
You have to really move quickly. And thankfully that happens very rarely.
And you must have to have a certain skill of, in an urgent situation, not raising that child's stress level even more so than you would say if I had an urgent situation.
Yep. You really have to stay calm and check your emotional response at the door. We've all been in situations where we know deep in our brain and our heart, this could go pretty badly pretty quickly.
Mm-hmm.
We have to sit down and be very calm and say to the family, concerned about your child, take some steps, have you right here with me. We're going to get them the help they need. And that really changes the dynamic in the room. You don't do that.
Oh, absolutely.
It can be, difficult.
So I wanted to get a little bit of background because hand, foot, and mouth, again, to a child, could be extremely scary. They don't know what's wrong. They've got these things on their hands and their feet and possibly in their mouths. And you had mentioned earlier, the blistering in the mouth, the rash in the mouth can be extremely painful.
Yeah.
So you have to be able to deal with that child, that 3-year-old or 10-year-old in a way that calms them down so that you can treat them properly.
True. Sometimes it's not possible when they're that significantly affected, particularly with the oral blisters, oral sores. They are excruciating. If you ever have hand, foot, mouth as an adult, you will be out of work for several days, I guarantee.
Oh, wow.
It is really not pleasant if you have the oral infection. So kids are drooling, they're crying, they're miserable. They can't always tell you. And so we don't walk in the room knowing they have hand, foot, mouth, particularly if they just have it in there.
Okay.
So that's why an oral exam is always really important in a sick pediatric patient. So figuring out how to get the exam, you're looking for certain things and you're looking very quickly because you're going to get just a snapshot, but they're truly miserable. So treatment is symptom control, pain relief, non-prescription relief.
I know in, for strep throat tests, there's the swab in the throat. What is the test to determine hand, foot, and mouth disease?
So there isn't a test to determine hand, foot, mouth disease per se. It's a clinical diagnosis, which means observe things clinically.
Okay.
Make the diagnosis. There are tests that can identify viruses. And if you're lucky and you get one of the viruses that is known to always cause hand, foot, mouth on that
was that the, what
swab
you say,
test,
the
Coxsackie virus is one of the main ones. Then, yeah, you can confirm to the family, oh, this is hand, foot, mouth disease. But we typically think of that test as unnecessary because it's not.
You've already visually.
It's not going to change our management.
Right.
What would be the utility? And you're torturing the kiddo even more by sticking something. Can't do that with strep because they require antibiotics. You don't want to use them necessarily. But for viral infections, treatment's probably not going to be that different. Unlike the flu, where we can give Tamiflu.
Right.
You can't do that for hand, foot, mouth. The treatment really is pain control. And most kids like this cold, delicious, sweet, liquid, semi-liquid foods.
Right. So if they've got the blistering in the mouth, it's the cold, exactly.
Jello, ice cream, anything to kind of not make them
That's the best part of being a pediatrician. I prescribe Jello.
That's right.
Ice cream.
It's fun. And that's where you can get into some trouble with kids is if they really are miserable and in such pain that they don't want to swallow, i.e. or eat, they can get dehydrated.
Right.
Those are the hand, foot, mouth patients that end up in the hospital.
Are there long-term repercussions of, like I know, again, coming back to chickenpox we talked about earlier, scarring, is there similar long-term signs or no?
No, not that, not that has been shown in the literature or in clinical experience, to my knowledge. Shingles is the chicken pox long-term potential.
Okay.
These viruses come and go in your system. You clear them, you have your skin reactions or your other system reactions, and then you're done, and you can get reinfected with a different strain or a different same one, unlike chicken pox where virus is living in your body for your whole life.
Okay.
The actual disease, that's not the case for vaccinated kids.
So there's really no treatment other than
Supportive care.
Yeah, and then
is what we call it.
And really no prevention either, because once it breaks out in a daycare, a school,
or your house,
yeah. It's going to happen. There's no putting something back in the can.
The genie back in
putting the genie back in the bottle, right? There's no going back. Once you get it, once it's there, it's there.
It is. I do think that there are certainly situations where a household of a few siblings, one kiddo gets it and the other two don't. We don't always understand that. I mean, it doesn't spread like wildfire. It just, that sometimes happens with any virus.
Right.
Kid has the flu, but the rest of the household doesn't get the flu. But typically, if they're young and they're sharing toys and fluids and straws, they're wiping all their fluids and things, touching everything. Yeah, people are going to get it. And a lot of emergency room doctors and primary care doctors get exposed to hand, foot, mouth a lot.
Right.
So they're probably, at least in pediatrics, one of the more likely to.
And then they bring it home.
Or get it themselves.
Well, we are up on our next commercial break. We will be right back, so stay with us.
This is 22 News in Focus with Patrick Berry. This is 22 News in Focus with Patrick Berry.
Welcome back, everyone, to this edition of InFocus. I am your host, Patrick Berry. Sitting across the desk from me today, I am very fortunate to be joined by the new chair of the Pediatrics Department at Baystate Health, Dr. Matthew Guglielmo. Doctor, thank you again for joining me and giving me some of your time today. We started off with one of the biggest things that's in the news lately that's kind of running rampant through our daycares, our preschool programs, and our schools and whatnot, hand, foot, and mouth disease, which is not to be confused with hoof and mouth disease, which I had done that. Hoof and mouth disease is a farm animal or a barn animal condition, but they do have some very similar names. But there is also another outbreak that's happening. I don't think it's really happening much here in Massachusetts, but it is happening in other parts of the country. It's measles, if I've got it correctly.
That's correct.
What is measles?
Measles is a viral infection as well that can affect a human at pretty much any age, but typically children. It is a combination of symptoms, including sores and spots in your mouth, skin rash.
So it could be very similar. Is there a chance for, I know your answer to this is going to be no, but is there a chance for a misdiagnosis between measles and hand, foot, and mouth disease?
I think it would be tough after a day or so.
Okay.
In the first day.
That distinct.
Yeah. If someone comes in and I notice some spots in my child's mouth and they're complaining about a sore mouth and they have a little bit of fever, but they don't have a skin rash yet. Sure, someone could think, oh, this could be hand, foot, mouth. It could be aphthous ulcers, which can be associated with autoimmune disorders. There's a lot of things on that list. But within a day or so, hand, foot, mouth kids probably aren't going to have the fever. They'll break out with the bumps on their hands or the sides of their feet or the palms of and soles of their feet. The rash will get worse. They'll drool more. Kids with measles, their fever will increase. They'll break out in a more, call it confluent rash. So instead of occasional little spots, it's like lots and lots of red dots, and then it spreads and it's covering your whole body. Your tongue gets thick and red. Your eyes are injected like pink eye, like conjunctivitis. Right. You've got a runny nose and you've got a cough. You just look very, very sick, usually within 1 to 2 days. That's a very different presentation of hand, foot, mouth. That would be not something I would expect to teach anyone about or see myself if it were hand, foot, mouth. If it were measles, and a lot of us haven't seen measles because there haven't been cases of measles for a very long time to the degree that we're seeing now. So you have to be ready for something to quickly turn and look quite different.
So, and in both cases, it's primarily among children just because of the environments that they live in, and I don't want to say unsanitary, but children wipe their nose with their back of their hand and then touch a toy and so forth. But children's environments are really where both measles and hand, foot, and mouth are going to spread mostly.
For sure. That's correct.
And if so, what is the treatment, I guess, for measles?
That's a tough one because it can be so serious. It can affect the brain. It can affect other parts of the body. Kids who get really sick need be in an ICU sometimes.
Wow.
Because it's a viral infection, there aren't antibiotics for it. And, we don't really use antivirals for measles. So you're hoping that the body copes with the infection and the immune system gets you through it. And you don't have some of the severe.
So similarly with the hand, foot, and mouth disease, it's as soon as a parent or guardian sees something, get an appointment with your pediatrician immediately. Is it one of those, the earlier detected, the easier, for lack of a better description, the easier time the patient will have with whatever they're diagnosed with?
In general?
Yeah.
Yeah. I mean, if, parents know their kids best, if they're seeing something that doesn't seem right, I think the first call should be to their pediatrician's office, talk to the pediatric nurse or the physician on call. This is what I'm seeing. This doesn't seem right. This seems different. What do you think? Oftentimes we'll want to see them in the office. Sometimes we can sort of give some counseling or assurance over the phone and call me in a day, call me in 2 days.
You bring up a very good point. Since COVID hit, telehealth has really taken off. So in a situation like this, it's probably much easier for both the parents and the families and the pediatrician.
Yeah, I have had a love-hate relationship with telehealth when it comes to
you and everybody else.
No, but specifically when it comes to rashes.
Okay.
Just because sometimes the technology isn't as good to be able to see the
right. Good point.
However, if they're describing what sounds like it could be hand, foot, mouth. Now there are things on the palms. Oh, let me see the foot. They hold the foot up to the camera. There's a couple of dots, and they're drooling. It might be hand, foot, mouth. Here's when you want to come in. If this happens, and here's what you can do in the meantime. Things that are more like chicken pox or bug bites or other sort of arthropod and insect infestations are really hard to tease apart on the screen. But telehealth is great for families, great for a lot of other pediatrics.
Are there any other things that, outbreaks, seasonal outbreaks, as we're heading into the tail end of 2025, winter's here, any other outbreaks that parents should be aware of during the winter months?
So we tend to see more flu in the winter. I think folks pretty much know that. There are a couple of viruses that are starting to sort of be more in the news. RSV.
What's RSV?
Respiratory syncytial virus.
Okay.
It's a virus that typically infects the very young, particularly premature infants and very young infants and toddlers. We can get it too, though. Our infections are much less severe. So there was the triple-demic a few years ago, RSV, flu, and COVID.
Right.
So RSV is seasonal. However, we're seeing less of it this year, which is very interesting. And there's a antibody towards RSV that we give to young children now. Families desire it. Has seemed to, so far, knock on wood, decrease our RSV season start, or perhaps our RSV season severity. Although it's early, my ICU and infectious disease and hospital doctors will probably be upset with me for predicting a lighter season, and the opposite. So flu, RSV, and then there are a handful of other respiratory viruses because we're in close contact.
Right.
That are typical.
Best advice for parents, just and guardians, your child best.
Yep. Have a good relationship with your pediatrician or family doc, open communication, and let us know when things are going on.
Fantastic. Doctor, thank you so very much for giving me a part of your time. I greatly appreciate it.
My pleasure. Thanks.
This is 22 News in Focus with Patrick Berry.